They're rushing them off to surgery, see. So that can be a sort of informal kind of planning, right? And during that process, you get a patient, it's a drop and go at Southwest General, gunshot wound, they're bleeding profusely. See? Sometimes that happens on the south side, that's true. Yeah, I've worked there, and that's what sometimes they call drops and go. But consider you're critically thinking, and you have to act instinctively and quickly because you're trying to save their lives. You must have that critical thinking, decision making, and maybe you have to have a little creativity involved. You're doing several things at once. Therefore, not all nursing care plans are written, sitting down and formally thought of. Because you've got to act if that person's dying. That's just how it is, and you'll have to do these interventions to help save their life. And you're doing it as a collaboratively with a multidisciplinary healthcare team. You're getting the surgeon there, getting the OR crew ready because you got to take them because they have gunshot wound, right? Things like that. You're setting up for a central line. Because you know instinctively you've got to get ready for the ER doctor to get a big, large bore IV central line in, so what? They can infuse blood products. You're getting the crash cart ready because, and opening it up already because you've got to get ready for intubation, putting the tube down to their lungs so they'll be able to breathe because they're starting to have angular breaths. Things like that. I tend to talk ICU language because that's where I'm from. Yeah. It's all good though. Want all of y'all to be medical intensive care nurses. Why not? So, again, with initial planning, it's that first patient contact. Actually, we talked about that in those other chapters. When you first walk into that door, actually, you could be making the assessment as you're walking down the hallway. You're hearing that patient's crackles. You haven't even gone into the room. You know that person's overloaded with fluid. As you walk in, you see that IV normal saline running at 150 milliliters an hour. You say, man, I wonder why that's doing that. Why did somebody leave that running all night like that? Common sense, critical thinking. Got to call a doctor, get that IV DC'd, and maybe give them a little spot of Lasix. You see. Diuretic, loop diuretic, right? Y'all are starting to learn some pharmacology. So initial plan, we talked about ongoing planning. That's it, you're going to constantly evaluate. So you have to make changes. And then discharge plan is begun at the moment that they walk in. We're already planning their discharge. We must make sure that they have the adequate resources. You have a patient that lives alone, and they have had a CVA, and they're going to require a wheelchair. But will you know, and see this part of being an RN, you're involved in their total plan, because before they go home, shouldn't you make sure that they're not living in a house that's got like a huge flight of stairs to get into their house? I mean, you might have to have a wheelchair ramp constructed. These kinds of things, and that's where like a case manager might come into play to assess these things. Just common sense, though. You can't, how does one get the wheelchair up a ramp of steps? You have to build a ramp. They might have to move their bed from the second floor down to the first floor. See, reconstruct. Those are part of our responsibilities. See, I didn't even realize. Forgot to put it that way. Stroke patient, right? So make sure it just makes sense to you. Make sure you're discharging a patient and you've got all the bases covered. That's your responsibility. Let that patient tell you. Get that patient's input or that family's input. Yes, I have a two-story house, and yes, the only way access to my house is by walking up steps from the front porch. We need to get some crew out there to build a ramp for the wheelchair. Right? Makes sense. We can't send them home that way. We can't do it. We've got to think of all these things. Somebody, for instance, that's been diagnosed with kidney failure, they come in and finally, on what they've decided, they want to try the peritoneal dialysis. Peritoneal dialysis is a mechanism. It's not the hemodialysis where they go to those treatment stations, you know, the treatment centers 3 times a week. Peritoneal can be done within the home if you have a very dedicated patient and family members. That would involve lots of comprehensive discharge planning, wouldn't it?
Yeah.
It's a lot going on with peritoneal dialysis, let me tell you. Y'all learn about that probably in Adult Health 1. I'm not sure where the renal component goes or falls in the program here. Pre-printed standardized plans. They save time. They do save time, and you'll find in hospitals they have, you know, it's electronic, these drop-down things. But of course, you guys in your beginning stages, y'all get to write these things, right? But remember, standardized care plans, plans of care, whatever you want to call them. You don't forget, every patient is individual. There's everyone. We're all different. Therefore, you also have to fine tune and hone, and you might even in these electronic nursing, the hospitals. There's place for freehand typing that you can add to it. But just know that standardized plans, they do save nursing time, and they do have that property of consistency, because we're making sure we're doing for that standard kind of patient. We should be following these types of things, i.e., we have a patient that has a fractured hip. There's certain things that we should be doing with that patient, right? There's certain steps that all fractured hips should do to proceed into the to back to health. There's just certain things, you know. So, but don't forget the individualized. And as you can see, I stuck an illustration of a care plan book. I don't work for the company, but I do say that a lot of students have found this is a nice care plan book. I don't know if they gave you your own. They recommend your a nursing diagnosis book, right? I found this has been a pretty good one too. Maybe y'all can find it on Amazon.com for $10, who knows? Anyway, we'll move on. Critical pathways. I think we talked about critical pathways in the last test, right? Didn't we talk about that? Talk about Texan Heart Hospital that now has been bought out by the Methodist system. I use this as an example. I even put up the open heart surgery patient. That's what they did it. Focus was on open heart surgeries, right? They use those at Texan Heart Hospital because it's a pathway that we can follow, that it saves the organization time and money. Because what we find is we weren't waiting for the doctor to come in and gave his blessing. Oh, okay, so now we can start bringing the patient off the ventilator. By following a pathway, it gave a little more autonomy to the respiratory technicians, to the nurses, to be able to function. You know, the patient's O2 saturation was 100% on the ventilator at 80%, so hence the respiratory therapist would titrate down on the oxygen, and they were maintaining a good 100% on their SAPs. So they switched them to what they call CPAP, which is it's just like a wind tunnel, low in that area, right? And then subsequently, within 18 hours post-op, they're already off the ventilator. And before the next day, before the doctor comes back in, he sees the patient sitting up in a cardiac chair. He comes in, he takes out the chest tubes from the post-op surgery, or from the surgery. And then by the afternoon, the physical therapist is walking the block. I call it walking the block. He really pushes those patients. And within 3 days, the patient's discharged. That's why we did it there. It was hard work, but that's it. Without complications, the patient could come in there, have open heart surgery, be discharged within 3 days. Nice place to work for. It's a nice facility. I don't know, I assume it's still good for being bought out by Methodist. I don't know what happened there. He was a doctor of hospital, Texas. I don't know. But that's the concept of critical pathways. I use my example, heart hospital. Okay, outcome, patient goals, outcomes. So after you've done the assessment, diagnostic, next step is goals, expected outcomes. Again, you're formulating these plans and you're working in conjunction with the patient. Does the patient think it's reasonable? By having buy-in with the patient, you're going to have more success with your plan. You make the decision. It's sort of like this. You've won a little lottery money, right? $100,000, whatever. You decide what you're going to do with your money, right? Someone else doesn't decide. The lottery people don't decide what they're going to do with your money, do they? You have buy-in, right? The client needs to have buy-in. And that will make the goal be more likely achieved. You have short-term and long-term goals. Short-term goals typically within a few hours or days. Long-term are changes in health status that you wish to achieve over either a longer period, a week or a month or more, or a lot of times you'll say prior to discharge. Could be a patient walks into the ER and they're feeling faint and dizzy, and you hook them up to the EKG, that's the heart monitor, and you see irregular beats, right? And so you decide, the doctor, and of course in your mind you're saying, man, I want to check that potassium level. That serum potassium, because potassium level is correlated with the electrical functioning in the heart to keep it regular. So you check that, and lo and behold, the minimum low where acceptable, what we find is 3.5 on a serum potassium level, and you find that this patient's potassium level is a 3. So by all means, we've got to get that corrected, because this is enough irritability with these electrolytes to actually throw the patient into a lethal arrhythmia. So what the doctor orders is, they'll call them potassium riders. And you give them slowly IV over the pump, 10 milliequivalents over an hour, mixed in about 100 milliliters of D5W or normal saline, whatever. And whatever amounts, and then you'll do a follow-up, a serum follow-up to see if it's raised in potassium. So in that case, that would be a short-term goal, wouldn't it? By the end of my shift, potassium level will have achieved within a normal range of 3.5. Short-term goal, right? Because they came in, they were 3. Long-term goal was prior to discharge, patient will be taught appropriate education on nutritional status to maintain proper nutrients. Be patient education in terms of medication compliance, because maybe all along they were on a potassium supplement. Maybe they were on Lasix, a loop diuretic, and what's lost in your diuresis is the potassium, right?
It's normal, 3.5 to 5.3.
Well, 3.5 to 5. Some lab references say 3.5 for potassium. Some I've seen 3.5 to up to like 5.3. It depends on what lab you use, but most times 3.5 to 5, something like that. I'm not sure what your book has. But what I'm saying is maybe that patient before, maybe they've always been on a loop diuretic such as Lasix and the supplement potassium. Maybe the doctor ordered liquid potassium. Has anyone ever tasted that stuff? It is awful. Let me tell you, it burns your tongue. The potassium elixir, oh, it's terrible. But then you have the other option of these K-Dur tablets, and I call them horse pills. These, even the 10 mil equivalents are quite big, but them 20 mil equivalent tablets, man, they're really big. But sometimes, see, maybe what it was is the patient didn't like taking them because they choked on them. So they just avoid the potassium pill. They take the Lasix, a little kind of white pill, right? But they weren't taking their K-Dur. And see, hence, that's what was causing them to get off kilter with their potassium in their body. See, they had low potassium. But you got to do patient teaching on the medication. You got to understand this Lasix will deplete your potassium. You got to do patient teaching. Make sure that with prior to discharge, the patient has clear understanding. Patient education. You might have to switch I asked doctors to reconsider the type of potassium pill because they do have caplet potassium too. Those cost a little more. Just things like that. But emphasize the importance. That's just an example. So long term could be months, it could be several weeks, it could be 6 months. You know, because see, you could use other terminologies on long term. Maybe it's a post-hip surgery, you know, and so they're going to get to stay in the hospital with DRGs the way they are. You know, maybe a week, as long as they don't have complications and demise. And maybe, you know, within 6 months, patient will have switched from using a walker to a cane. Yeah, that's reasonable with physical therapy coming in to their home weekly. Because you guys might, a lot of y'all might be home health nurses, you see, case managers and health agents. Okay, here, this is when we're writing these nursing diagnoses and goal statements. The subject's always to be understood as the patient, right? And I like to use my husband, you know. So in parentheses, I put Mr. Moore, but you know it's a given. You wouldn't write patient. You'd say, we'll walk to the doorway. Notice how I've made it as exact as possible. We'll walk to the doorway with the help of one person. And I put a date, by 9/11. Lung sounds. It's understood it's Mr. Moore's lung sounds, right? Mm-hmm. It's understood that Mr. Moore's oxygen saturation will be above 92% while performing ADL. And down here I did put it, I said think client or patient will, but don't write that in your statement. See, and that's a way of writing nurses' notes too. When you write nurses' notes, you're not going to write patient or Mr. Moore or something. You're going to write ambulated to the bathroom with a system 1 gate unsteady or something like that. These are some action verbs. I just highlight different colors. Concrete verbs, and then the action is about the walk, the physical activity, right? But these are some descriptive action words to consider when you talk about how you formulate your statements. Just sort of consider them. These are things that we would use probably in our day-to-day activities with nursing. I should not turn my back on you guys. That's a bad habit I have. I must come over here to this part. I apologize. Performance criteria. Performance criteria, those are the standards for evaluating the client's performance. These need to be concrete, observable. And again, I use those examples. I can observe that he walked to the doorway with the assist of my CNA. I observed it. I observed it. I looked at his tray after he ate, and he ate just about 100% of his diet. Sometimes the doctor wants you to do a calorie count, and that's what he's doing. He's wanting you to look at the tray, make sure they're eating, right? I can observe these things. I can observe and therefore document. Targeted times. Targeted times is the when part of the performance, and you want to be specific. By discharge, within the change of my shift, that serum potassium would be up to 3.5 because it was at 3, remember? Targeted times. Make it as specific as you can. Sometimes it becomes minute by minute because depending on the patient, what kind of crisis mode they're in. So on target, on time, that was my illustration. Timeliness. Be exact. Be as most exact as possible that you can be. And then you want to think about some special conditions. There might be some situations, like for this example, impaired memory related to fluid and electrolyte imbalance as manifested by, and remember I told you, you might see on your test AMB, and you'll know what that means, right? As manifested by. Inability to recall recent events. The outcome goal might be that the patient can demonstrate techniques to help with memory loss. Maybe we have provided them some teaching, some tools, some devices to help them with memory loss. And then now they're going to demonstrate, right? So here, let's put it all together. Nursing diagnosis, here's an example, risk for constipation related to inadequate fluid intake. You can consider that yourself. We could have that, couldn't we? If we don't take in enough fluid ourselves, we are at risk for constipation, right? Just because they're the patient don't mean we don't have these problems. Expected outcome, bowel movement will be of normal frequency and consistency. Targeted time, we want it at all times, right? We want to evaluate our patient daily. Did you have a bowel movement today? What kind of stool was it if you didn't see it, right? And they'll tell you it was normal. It was soft, it was brown or it was dark or whatever. See what I'm saying? These are important because I tell you, that's one of the worst problems that we find in the hospital. Patients have problems with constipation. So I don't mind using that as the example. Patients frequently, because why? They're not in their own home environment. They don't feel comfortable. Don't you admit, if you're not in your own home environment, you're visiting, don't you, right? Mm-hmm. Y'all know what I'm saying.
Yeah, we do.
You understand that, okay. So why would it be different? Because that's called a patient. They go into a hospital, it's a cold environment, you know. Concrete floor. It's not like my home, and I have my TV in my bathroom or whatever it is. I can have diversions, right? You know what I'm saying. So make sure too that y'all review those pages 94, 95. It gives you some examples, some more examples to help you have better understanding of the diagnosis goals and expected outcomes. Nursing outcomes classification. That's another tool that's been out there. And of course, these came from the, all this stuff seemed to be, they must have had a powwow at the Iowa or something, University of Iowa or something. They started developing this stuff. Somebody, some PhD person must have been there. But nursing outcome classification, it has more than 385 nursing sensitive outcomes. I mean, somebody must have set, or a group, a think tank, like you guys have your think tanks, y'all break up into. They must have had that there. And they developed these topics. And I think probably you could probably find these within your electronic tools that you have in your CD, most likely. They have them. But you also can find some of these on your pages 96 and 97. We're moving on to chapter 6. I'm doing pretty good. Planning and interventions. Remember we said planning and interventions, implementation, they sort of go hand in hand. We're in the planning process, and these are these action things. Whether we're doing, this is depicting what? That they're given some sort of education idea, right? Direct care. We show them, and you guys will do this for your skills checkoff. We have the mobility checkoff where you have to do, you have to demonstrate. This is how I do it if you have me to test you off. With mobility, I have you with a partner, and I tell you that, and I let you draw like in Las Vegas playing cards. You know, so it's fair and balanced. I didn't tell you what to do. You picked your poison, right? So you look at the card and say, man, I'm the nurse, and I've got to give patient teaching, and I got to teach this patient that's how to use crutches and do a 4-point gait or a 2-point swing-through gait, right? You guys, if you go to your ATI, you'll see all these stuff that talks about mobility, right? So different types of gaits. You're the nurse, you teach, and then you let them demonstrate. Just like you have somebody that's a new diabetic, and before discharge, I mean, they're going to go home on insulin, right? So you teach them how to draw up their insulin and administer their insulin shot. And then you let them do it. You teach them how to check their blood sugar with the machine that they're going to go home on. And then you let them demonstrate, return demonstration, right? That's how we all learn. We all learn it that way. Indirect care might be a consulting group. Might be where it's a group of clients coming together and for whatever they're being talked to. Maybe it's, I don't want to say it's a support group, but it could be in terms of, let me think, like maybe you know, new mothers or new fathers parenting classes. That would be something. That's sort of like you'd have a consultant that would bring together a group of clients.
It's not one-on-one, it's just more.
Yeah, so a group kind of interaction, and you know what I'm talking about. The parenting classes, then they all come in together. Sort of indirect, but direct. I'm working with you to teach you how to check your blood sugar. Now I want to watch you check your blood sugar, something like that.
Direct, would that be like going to like a lactation specialist?
Yeah, or it could be a group of them, a group of clients that have the same kind of condition going on, something like that. It wouldn't be
one-on-one.
she's the newly diabetic. I'm gonna teach her how to check her blood sugar every day. This is the machine you're going home with. Now I'm gonna show you how to check your blood sugar with this machine, and now I want you to demonstrate how to do it. That's one-on-one. That's direct, you see.
So it's kind of like direct being related to the actual patient itself on how to versus a generalized.
Yeah, generalized.
And a generalized direction on how to do something specific to.
Yeah. Because you might have a group. The parenting thing was the best one I could come up with, to be honest, at this moment. I might come up with a better one, but direct is, or those crutches. They're going to go home on them crutches. I've got to teach them how to use them properly. I show them, and then they return demonstration.